Hi everyone, and welcome to our module on diabetic ketoacidosis. Diabetic ketoacidosis, or DKA, is a life-threatening complication of diabetes. DKA is a biochemical derangement. Patients who develop this condition have hyperglycemia and acidosis and other biochemical abnormalities on lab testing that we'll talk about later in this video. In order for DKA to develop, a patient must have very low insulin effects. So to understand this, let's look at the bottom of the screen. So you may know that insulin lowers blood glucose levels by triggering cells in the body to take up glucose from the plasma. But there are other hormones like epinephrine and also glucagon and cortisol that are called anti-insulin hormones, and that's because these hormones oppose the effects of insulin and they raise the blood glucose level. So in order for a patient to develop DKA, they must have very low insulin effects in the body. That can happen either because the amount of insulin in the body is very low or because the epinephrine levels are very high because epinephrine opposes insulin. And so if you understand this, it's easy to understand that diabetic ketoacidosis is more common in type 1 diabetes because those patients are unable to produce insulin. And in fact, DKA is a common initial presentation in a patient who presents for the first time with new onset type 1 diabetes. You should also know that diabetic ketoacidosis is often precipitated by infection or trauma. That's because these things raise epinephrine levels in the body. And like I said, epinephrine opposes insulin. So if you have a patient with diabetes whose insulin levels are low at baseline, and then they develop an infection or have trauma or surgery, their epinephrine levels can go up, and that can tip them into DKA. You can also develop DKA if a patient has type 1 diabetes and misses insulin doses. This will lead to very low insulin levels, and that can put the body into DKA. So putting this all together, the way to understand DKA is that either high epinephrine or low insulin levels, or a combination of the two, leads to hyperglycemia and increased glucose, which is one element of DKA. The other element is that very low insulin effects leads to ketone body synthesis by the liver. When insulin levels are very low, the liver assumes it is in a starvation mode and it begins to produce ketone bodies, which can be used by the brain for fuel. So the net result of these two phenomena here is that patients with DKA will develop hyperglycemia and the presence of ketones in the plasma. What happens next is an osmotic diuresis occurs. When glucose levels are very high, glucose spills into the urine and it pulls free water with it. And this leads to high urinary volume, and that will lead to volume depletion, which is another element of DKA. And then when the ketone levels are high in the plasma, some of the ketone bodies synthesized by the liver are acids, so this will lead to an anion gap metabolic acidosis. DKA is a classic cause of an elevated anion gap metabolic acidosis. And then finally, as the acidosis sets in, this can lead to hyperkalemia, another element of DKA. And so I've summarized these things on this slide, and you need to burn this presentation into your mind so that you can easily recognize it either in real life or in a board question. So a patient with diabetes who develops DKA is going to develop hyperglycemia. The bicarbonate level will be low, and that's because of the metabolic acidosis. There will be hyperkalemia, and on exam the patient will have evidence of volume depletion. So now that we understand that, we can talk about the clinical presentation of diabetic ketoacidosis. So in terms of symptoms, patients who go into DKA classically develop abdominal pain, nausea, and vomiting. These are non-specific symptoms, but in a patient who has established diabetes, this should raise the level of concern that the patient might be in diabetic ketoacidosis. On exam, there's going to be evidence of volume depletion. Remember, these patients have increased urinary volume from glucose in the urine, and they also have vomiting. And so for both reasons, they can become very volume depleted, and they can have dry mucous membranes and low blood pressure. And then when you do labs, you're going to see those three classic findings of DKA: hyperglycemia, a low bicarbonate from acidosis, and hyperkalemia. Some other elements of the clinical presentation of DKA: you can send a blood test to the lab to measure the ketones in the plasma, and they will be elevated. You can also detect urinary ketones with a simple dipstick test. Dipstick testing of the urine will also show glucose in the urine. In patients who have DKA, they have hyperglycemia, and some of that glucose is spilling into the urine. And then, as I said before, they will develop an anion gap metabolic acidosis, which means laboratory testing will show a low serum bicarbonate. These patients can also demonstrate Kussmaul breathing. This is deep labored breathing. And this is caused because the patient is trying to hyperventilate and blow off carbon dioxide to raise the pH and counteract the metabolic acidosis. And then lastly, patients can have a fruity smell on their breath, and that's because one of the ketone bodies produced by the liver is acetone, and acetone gives a fruity smell to the breath. Patients with diabetic ketoacidosis can develop low phosphate levels, meaning hypophosphatemia, and this occurs because there's phosphate loss in the urine, which is called phosphaturia, when the patient develops an osmotic diuresis. Basically, that high urinary flow pulls phosphate into the urine and out of the body. When this happens, cells can lack enough phosphate to make ATP, so this can lead to muscle weakness if the phosphate level is very low. This presents as respiratory failure. It can also potentially lead to heart failure from decreased myocardial contractility. So when patients are in DKA, we always closely monitor the phosphate level, and we replete phosphate as needed, which we'll talk more about later in this video. Some other features of DKA to be aware of: patients can develop arrhythmias, and that's because of the hyperkalemia. And then cerebral edema does sometimes happen in severe DKA. The mechanism is poorly understood, but this is unfortunately a common cause of death in children who develop DKA. They develop brain swelling and permanent neurologic damage. So the diagnostic criteria for DKA are the triad of hyperglycemia, an anion gap acidosis, and the presence of ketones in the plasma. Typical lab values that you will see are shown in this table. So the glucose level is almost always above 250. It has to be significantly elevated for DKA to develop. It's usually in the range of 500 or so, and importantly, it usually doesn't get as high as 800 to 1000. When that happens, patients develop a hyperosmolar syndrome, which we'll talk about later in this video. DKA usually has lower glucose values, somewhere around 500 or so. If you do a blood gas, the arterial pH will be low, usually less than 7.3. And remember that the bicarbonate is going to be low, less than 18, and that's because of the acidosis. And then urinary testing for ketones will be positive, and serum testing for ketones will be positive as well. The treatment of diabetic ketoacidosis mostly involves the administration of intravenous fluids and intravenous insulin. The fluids are necessary for volume replacement. Usually normal saline is administered, and it's usually infused continuously. IV insulin is important for a couple of reasons. First of all, it lowers blood glucose levels, but more importantly, it inhibits the liver production of ketones, which will resolve the metabolic acidosis. It also shifts potassium into cells, which can help to resolve the hyperkalemia. And usually insulin is given as an intravenous bolus followed by a continuous drip. Another important element of the treatment of DKA is the administration of potassium. Now, it might seem crazy to give potassium to a patient with DKA when DKA is associated with hyperkalemia, but the reason potassium is necessary is because the total body potassium in patients with ketoacidosis is low because they are losing potassium in the urine. They present with hyperkalemia, but this is misleading. Their serum potassium is up because of acidosis and low insulin. This shifts potassium out of cells and into the plasma, causing hyperkalemia even though their total body potassium is actually low. What this means is once you begin treating them with an insulin infusion, you will shift potassium back into cells, and these patients can develop hypokalemia that can potentially be life-threatening. So when you're treating a patient with diabetic ketoacidosis, you add potassium to the intravenous fluids once the serum potassium level has fallen to less than 5.3. When they present, if the potassium is above 5.3, you don't give potassium in the fluids, but once the potassium comes down below this value, you add potassium to the fluids. This is a super high yield point for your boards and for real life. It's important to understand that even though the potassium is high in the serum when patients initially present, they are actually total body depleted of potassium because of loss of potassium in the urine. Besides potassium, you also have to keep an eye on the other electrolytes in patients with DKA. At presentation and during treatment, it's routine to monitor the magnesium, the calcium, and the phosphate. These levels all can fall due to loss in the urine, just like we talked about earlier for phosphate. And so if they get low, you replete them as needed. And then you might think that a bicarbonate infusion would be helpful because these patients have acidosis and a low bicarbonate, but usually bicarbonate infusion is not necessary, and that's because the arterial pH will come up naturally as you treat DKA. Remember that the insulin is going to suppress production of ketoacids from the liver, and so that will usually bring up the plasma pH and resolve the acidosis. So a bicarbonate infusion is usually only indicated if the pH is very low, like below 6.9, because when it gets this low, it can impair cardiac function. Now let's talk about how you monitor treatment in a patient with DKA. So when the patient presents, you begin treatment with intravenous fluids and insulin, and after that you closely monitor the serum glucose and electrolytes. When the glucose value approaches 200, which is very close to the normal range, at that point you need to add 5% dextrose to the saline infusion. Dextrose is a version of glucose, and you're probably thinking, why would you want to add glucose to the infusion in a patient with DKA who has hyperglycemia? But the reason this is necessary is because it allows you to continue the insulin infusion to suppress the production of ketones from the liver. Remember, insulin has two purposes here. One is to bring down the blood sugar, but the other is to suppress the production of keto acids from the liver. And you want to keep suppressing that production from the liver, and in order to do that, you need to add dextrose to the infusion when the blood glucose level gets down to 200. If you didn't do this, the patient could develop hypoglycemia. In addition to adding 5% dextrose, you can also decrease the insulin infusion rate when the glucose approaches 200. But importantly, you don't want to stop the insulin until the DKA has resolved. And so how do you know when the DKA has resolved? Well, first of all, the anion gap has to normalize. It has to become less than 12. What's causing that anion gap are the keto acids from the liver. So it's elevated at presentation and it comes down with treatment. So when it comes down to less than 12, the normal range, then you know you've suppressed ketone body production by the liver enough so that the patient no longer has an anion gap. You can also measure the amount of beta-hydroxybutyrate in the plasma. Beta-hydroxybutyrate is one of the ketone bodies synthesized by the liver. So if it is absent, then that means you have resolved the ketone body production by the liver. This is not available in all labs, so in most cases, instead of measuring beta-hydroxybutyrate, you simply monitor the anion gap. And then lastly, the patient has to be able to eat. If the patient is still nauseous and unable to eat, the DKA is not considered resolved. Now let's move away from DKA and talk about HHS, which is hyperglycemic hyperosmolar syndrome. Like DKA, this is a life-threatening complication of diabetes. However, HHS is more common in type 2 diabetes, whereas DKA is more common in type 1, like I mentioned earlier. The problem in HHS is markedly elevated blood glucose. It can be as high as 1,000 or greater, which is severely elevated. When the glucose gets this high, it leads to an osmotic diuresis and volume depletion. It also causes the plasma osmolarity to get very, very high, and this can lead to central nervous system dysfunction. In contrast to DKA, however, patients with HHS usually have no acidosis, and that's because they have insulin present. That's why this is more common in type 2. Because some insulin is present, the liver doesn't go into starvation mode and produce keto acids, but the glucose can still get very high, and that's what leads to the clinical problems of HHS. The main problem in HHS is very high serum osmolarity. This can draw water out of brain tissue and cause CNS dysfunction, which can become life-threatening. If you look at the bottom of the screen, this is the equation for serum osmolarity. It's equal to 2 times the sodium concentration plus the glucose concentration over 18 plus the BUN over 2.8. So a normal glucose is about 100 or so, and you can imagine that if instead it gets up to 1,000, that this can cause the serum osmolarity to become very high. And a normal plasma osmolarity is less than 300. In patients who have HHS, it usually gets above 320. And as I mentioned on the last slide, this is different from DKA because there are usually few or no ketone bodies present in the plasma, and that's because insulin is present in patients with HHS. So they don't develop an acidosis because the liver is not producing keto acids, and this distinguishes HHS from DKA. Remember what I said earlier, in DKA, the hyperglycemia usually causes a glucose level around 500 or so. In contrast, for patients to get HHS, the glucose usually has to get above 800, and often it's even higher than 1,000. In terms of clinical features, HHS presents with polyuria, polydipsia, and volume depletion. And these things are all related to hyperglycemia and osmotic diuresis. And then the high plasma osmolarity will draw fluid out of brain tissue, causing mental status changes like confusion and even coma. And when you see these things in a patient with diabetes, a blood glucose is usually checked, and that's how the diagnosis is made, by finding an elevated serum glucose. The treatment of HHS is similar to diabetic ketoacidosis. It involves insulin and intravenous fluids. However, unlike DKA, there isn't an increased anion gap in patients with HHS, so you don't need to administer insulin until the anion gap has closed because there isn't one to begin with. Instead, HHS is resolved when the plasma osmolarity falls back towards normal and becomes below 315, as well as when the patient is alert and able to eat. And remember that the major driver of the high plasma osmolarity in HHS is hyperglycemia. So when the glucose comes back down to normal, usually the osmolarity is going to be below 315, and then if the patient is alert and able to eat, the condition is considered resolved. And that concludes our module on diabetic ketoacidosis.